professor, physician, epidemiologist. I am Dr. Sri Banerjee. Hello, everyone. I am Dr. Sri Banerjee, core faculty for the College of Health Professions at Walden University, and it is with great honor that I am presenting this topic in front of the conference on statistical practice. This year, this was, I know, supposed to be held at New Orleans, but we're fortunate enough to be able to, through everything that has gone on, able to present this topic. So I'm really happy to be able to provide you with all of the information surrounding this research area. Before I get started, though, I wanted to point out also that unfortunately, one of our colleagues, one of the individuals that I've looked up to and have used his technique that he found in the 70s has passed away recently. He passed away on January 18th of this year. So I wanted to take a moment to recognize him, and these are some of his more recent pictures that was on social media. Again, I wanted to make sure to introduce myself. I'm Dr. Sri Banerjee. I teach a lot of technical statistical courses and surveillance courses as it pertains to public health. And my colleague, Dr. Patrick Dunn, he is also a faculty member and also is affiliated with the American Heart Association and does a lot of work in the area of artificial intelligence. So drawing from some of this research and some of this insight, we were able to provide you with what is to come in this presentation. So stay tuned here and stay awake, and we'll be going through this. So first of all, I want to make sure to get started with the objectives. We're going to be going over, of course, starting with talking about some of the different models. We'll be getting into boosting and gradient boosting some here, but also making sure we have enough coverage in understanding how this connection between physical health and mental health is. And I want to not only focus on the methodology that is used here, but the content and the implications of the findings of this research. So not only am I going to be in the next 15-20 minutes providing you with an overview of the complexity of finding relationships between physical and mental health, but also I'll be showing you some innovative methodologies that have been tried and that I've been trying out to understand this a little better. So there's going to be three prediction models we're going to be focusing on. One predicting hypertension, which was the cardiovascular disease portion. And then one was looking at diabetes. We looked at prediction models for diabetes, and then finally prediction models for depression. And as I'll explain to you in subsequent slides, this is from the National Health and Nutrition Examination Survey. Okay, so as I said, the National Health and Nutrition Examination Survey is a extremely robust survey. There's about 5,000 people that are surveyed each year, but specifically it's a combination of nutritional health, of overall health, of physical health, all throughout the life course. So children, adults, all individuals are included within this. This is part of the National Center for Health Statistics. It's vital and health statistics for the nation, and it was something that is time tested. It was started in the 60s and now has been going on around 80 years. In the pandemic, during the pandemic, it's been going on for about 60 years, and during the pandemic there was a slight pause in data collection. So for machine learning purposes, these are extremely wonderful data sets. But as you can see, I've um, conducted a lot of collaborative research in the area of National Health and Nutrition Examination Survey in the areas of cardiovascular disease. But it doesn't just we're not just limited to cardiovascular disease because there's also, as you can see, sleep medicine. There's studies related to inflammation. There's also studies in here that you can see that is associated with drug use, stroke. So there's a lot of different areas. Also environmental health, endocrine disruptors. So what I want you to leave here with that slide is the appreciation that NHANES can be used in many different subject areas to study a lot of public health areas, but also bridging the gap between many disciplines to understand what exactly is going on. So bridging the gap between mental health and physical health. If you look to the right of your screen, you'll find that while there's 10% in certain study populations with diabetes distress only, and 12% maybe with depressive symptoms only, there's actually a intersection or a common 13% that experience both diabetes and depression. So you'll be seeing similar sorts of percentages and statistics when it pertains to the overlap between depression and cardiovascular disease. And as you know, cardiovascular disease is the number one killer in the United States. It's the number one cause of mortality within the United States. So, thinking about what we could be doing to try to understand this, an area of um, public health, an area of medicine, which is carrying much more traction more recently, is the area of precision. And the idea is that some of the more epigenetic, genetic, biomarker information that we have more recently gotten to know, let's start applying these to make better predictive um, uh, treatment and interventions for individuals. And so it is also useful in understanding social factors because we're able to group um, similarities between individuals in different ways than we have in the past. So usually, many times race was such a broad variable that some of these specific subcategories were not explored. But machine learning and artificial intelligence allows us to then bridge the gap between all of these disciplines and better understand a more cohesive sort of message from how to understand this. So moving forward, I wanted to also give you the appreciation of how when we're trying to determine the proper level of complexity that is in any sort of model, we have to be careful of underfitting versus overfitting and the validation error. So in error, when there's too few parameters, then there's potential for error. But as you start considering more variables, that error starts to decrease. But then, of course, as you go into more and more variables, there's overfitting. But when you have when you're training your data set, then these errors don't persist as much. So also I wanted to introduce the concept of ensemble learning, but more so how in an iterative gradient a manner in you can boost ensemble learning and in an iterative manner make it a better predictive model. The aim of a lot of these artificial intelligence improvements, innovations, is to at the end make better predictions of disease so that interventions can be made in a more tailored and targeted fashion. So here you could see I made a depiction of depression versus diabetes and artificial intelligence being bridging the gap. But same could be said about depression versus cardiovascular disease. Same can be said about other conditions as well. And I wanted to go over this naive model that is at the top. And so if you calculate the errors from this naive model, we start off with this model, and then we we build the model over here, and then once you build the model, you add last model to the ensemble. So it's an iterative process, and so this takes place. So if we're thinking about how to do this, the best way to do this is either through R or Python. Here, I personally have used R and like how some of the programs are set up. And you can see this is part of the code that I used. And so some of the variable names are there. And then you can see the data 2 is the name that I gave, and NHANES is actually the data set, and I only selected the number of variables that I was interested in primarily, and then um, and then went from there. So when we were doing this, we were trying to look for the main variables that were um, that we were most interested in finding more about. So the first outcome variable, of course, we were looking for is hypertension, and the predictor variable we were looking at was depression. So the first mean square error, this is a graphic of lambda at a logarithmic scale. And as you can see, when we're trying to understand the optimized lambda, to apply to our model, we want to find the value of lambda that gives the minimum mean cross-validated error. So this is the value that we found to be here was 0.034. This was applied then to the model. And then, of course, a decision tree was generated, and this was the decision tree. So one example of this would be classification based on age. So according to the decision tree, according to this portion of it, you can classify predictive models based on age, and the cutoff point being 53. This cutoff point was optimized by the selection. So another cutoff point that was selected, of course, it was between male versus female, and then once the selection was made, if you then go down here, you can find that there was another cutoff point at 43. So this, if you look from top to bottom, you can follow this along, do the same thing to the right. One cutoff point was by age, and then the second cutoff point by age. And then over here, the days alcohol, the days the person drank alcohol. So that had a predictive measurement on systolic blood pressure. Um, Moving to the next slide, we see that if you look at the mean decrease in Gini, so this is a in a very rudimentary and basic way to think about this is how to rank the level of importance of each of the predictor variables. So as we can expect, age, of course, is a strong predictor of high blood pressure because, of course, as we age, the calcification increases within, and hardening of the arteries take place. But also, what is interesting and important is that household income is important, and that is expected because social factors, of course, are at the forefront. But what is also interesting to note is that alcohol intake is just as important. So this is something that is good to keep in mind because that is also a variable that is of interest. If you think about all of the other um, variables and the ones that were most important, I think it's important to note how the order is. So while employment was important, if you look at the next one down, depression was just as important almost in predicting high blood pressure. Then it was sleep trouble, then gender, and then finally diabetes status. And so diabetes status, one would expect to have more of an influence because of the physiological effect that sugar has on the pathophysiological development of atherosclerosis and hypertension. So moving forward, if we think about the gradient boosting algorithm, what it does is it avoids overfitting on the gradient. So the gradient is approximated with a new weak learner. And so what you do is start with the constant, then you fit something called a weak learner um, to the negative gradient, and then take a step gamma which minimizes the loss. So it's an iterative process to minimize loss and to avoid overfitting. And as you saw in that first graphic earlier in the presentation, when you have overfitting, this leads to more error, and oftentimes you're not able to make sense of the model. So awareness of this is really important, and gradient boosting and adaptive boosting are important techniques and strategies through which that can be adjusted. So looking for adaptive boosting, of course, first boosting algorithms to be adapted in solving practices. And then what is the advantage? Another advantage of adaptive boosting is that it helps you combine multiple weak classifiers into a single strong classifier. But comparing adaptive and gradient boosting, adaptive boosting it is first designed. It was the first design boosting algorithm with a particular loss function, but gradient boosting is a generic algorithm that assists in searching the approximate solutions to the additive modeling problem. So basically, the main difference is that gradient boosting is a generic algorithm to find solutions and then to the additive model, while adaptive boosting can be seen more of a special case with a particular loss function. So gradient boosting can be more flexible. Adaptive boosting is more for an intuitive perspective. So let's look at how, when we were predicting diabetes, we've already looked at predicting hypertension, but let's look at predicting diabetes and the relationship, how depression is playing a role. So we've already gone through these steps before, and so I'm not going to go over them again in this stage. But what I do want to emphasize on, again, age as expected does play a role, as does household income in previous models. But as we can see here again, depression status has a pretty major role in predicting in predicting diabetes as well. Um, so so let's now take a look at um, what the predictors of diabetes are. And so again, looking at the predictors of diabetes, um, here depression was still, um, pretty high up in relative importance. So now from shifting from diabetes to depression, let's take a look at, of course, this is lambda optimization, but let's take a look at the relative importance. For predicting depression, um, so unlike when predicting diabetes and high blood pressure, depression played a major role. When predicting depression, diabetes actually doesn't play as big a role. So this is also pretty important. But another important finding was that alcohol and household income are kind of um, similar in predicting depression. So how did these models roll and fare in comparison to each other? Well, they fared pretty well, and the boosted and out of all of them, the boosting was the best process. Gradient boosting and adaptive boosting um, had much better accuracy than regular ensemble models. And so in all of these relationships, there's some interesting findings. So cardiovascular disease, of course, is defined as high, can be defined as high blood pressure because as we know, high blood pressure leads to ultimately heart disease. So um, we can kind of proxy blood pressure for cardiovascular disease. So if we were to do that, then there's definitely an association with depression. Then thinking about boosting, this is performing superior to regular sort of ensemble learning models. And of course, while there's a physiological connection between diabetes and hypertension, surprisingly, connection between depression and hypertension, according to our models, was stronger. And then finally, alcohol use should be seen as a social factor as well, because in some predictive models, this was seen as an important predictor. So these are all important findings. Artificial intelligence is critical and key, not only in public health, but also in collaborative research and better understanding and improving health outcomes in individuals and in communities all across the United States and all across the globe. Thank you for listening to this presentation.